Okay, so it's 8:45 and we'll start this session on acute coronary syndrome. As you all know, this will be a non-formal sort of discussion which we do. It's not based on PPTs and preformed lectures. It's based on the idea is you read a topic, you jot down the important points, whatever format you want, and then we can have a discussion regarding that so that we can clarify the practical aspects of that particular topic. So today the session will be taken by Dr. Radhika, and we'll be discussing the practical aspects of it, some around 45 to 60 minutes. So Radhika, you can start now.
Good evening, sir, and everybody. Today we are going to discuss myocardial infarction, which is one of the important conditions we are dealing usually in ICU practice. So basically, we are going to focus on the interpretation, basically to make the diagnosis and the treatment part of the myocardial infarction, because it is important for us in the ICU practice. So I will be starting with the definition of myocardial infarction. So we can define myocardial infarction as a condition which occurs due to a low blood flow in the coronary arteries. That is because of atherosclerosis or occlusion due to any thrombus or embolus. The myocardial infarction is classified in 5 types. The first one is spontaneous MI, which is because of the occlusion of a coronary artery. The second type is secondary to the mismatch between the supply and the demand of the oxygen to myocardium. The third type is a sudden cardiac death. Type 4A is secondary to PCI. 4B is secondary to stent thrombosis, and type 5 is associated with the post CABG.
Okay, so these are the types of MI which we have discussed, type 1 to 5. So what we will be dealing with today will be the type 1, in which there is a atherosclerotic plaque rupture and there is a blockage of the vessel. The other types of MI are the MIs, the one which is very common in ICU when we see raised troponin is oxygen supply demand, type 2. The third one is you cannot diagnose that MI, but on autopsy you find that this was due to cardiac death, so sudden cardiac death. This is you cannot pick in the ICU, but you can assume on autopsy. Now the fourth one is important. Most of the places there it is written as 4A, 4B. At some places it was 4C. I am missing it out, so you can note it down. Your homework is to find what is 4C. If somebody can search it, we can discuss in the end. 4A is after a coronary intervention, like you are doing an procedure, and during a procedure what happened, suppose there is a main vessel, but to place a stent in that particular vessel there is a compromise of one of the tributaries, and that has led to certain myocardial infarction. So that is 4A, and 4B stent thrombosis. Now, what is the troponin level on which you will call it as a this is due to stent thrombosis? Suppose you do a tropi and it comes out.
Troponin levels are more than 5 times of its upper limit, we will call it secondary to PCI
Okay.
or stent thrombosis.
And the type 5 is because of post CABG. So
CABG.
that also troponin level in the
will be more than 10 times of upper limit.
10 times the baseline level. So this is the type of things which now Anvi has written in the chat box, type 4 restenosis. Okay. So 4C is ischemic injury associated with restenosis. So Anvi, if you can unmute and explain what is the difference between type 4B and 4C, because 4B is due to stent thrombosis. And this means patient has discharged well, and now there is another stenosis. There is no thrombus, but there is no restenosis without thrombosis in that particular stent. Okay, that is 4C. So that is good. Thank you. So we'll be discussing the type 1 MI, in which their pathology is plaque rupture. Okay, Radhika. So I will be interrupting you in between so that we are all on the same page. Hai na?
Yes, sir. So first, to diagnose the MI, that is in ECG, our goal basically is as a first medical contact to make the diagnosis of STEMI within 10 minutes. So the diagnosis will be based on ECG and cardiac biomarkers.
So how this patient will present to emergency or your ICU?
Patient typically come with the typical severe chest pain, and we will be complaining the pain is radiating towards left arm, radiating to throat, jaw. The autonomic symptoms can be present like a patient will be tachypneic, tachycardiac, or with the perspiration.
Anything typical about this pain characteristic, more about this pain characteristic, chest pain? There will be heaviness.
Severe intensity and will be more than 20 minutes.
20
and
minutes.
It will not be subsided by rest and some medications also.
I mean, it's no, by medication it can subside if he has taken sorbitrate, but it will not be varying with the posture or the movement. And usually the duration of the pain will be persistent for more than 20 minutes. So anybody who wants to add something, you can add in the chat box, because we all are learning in this way. So typically this is the characteristic of chest pain. So suppose this patient comes to emergency or ICU with a chest pain which is of heaviness and radiating to jaw, it can radiate to both arms also, more than 20 minutes. And now what will you do?
First, we have to make the diagnosis as soon as possible. That is, our goal time is within 10 minutes. So we initially will go for an ECG and interpretation and make the diagnosis depends on it. So if we find ST elevations in respective leads,
so
we
first
can
we will
make
do
the
an
diagnosis of yes.
Okay, so you will do an ECG.
Focused history also, and physical examination also.
And what is important in doing physical examination of this patient?
First of all, hemodynamics of the patient, and in auscultations.
No, that we have, that is common. You will auscultate the heart sound, chest. Specifically, which we need to monitor, specifically observe in this patient. I'll palpate all 4 limbs so that it is not aortic dissection sort of thing. If there is a radiofemoral delay or so, because thrombolysis is contraindicated. So make it habit of palpating all 4 limbs. So, okay. So we'll do an ECG and then you will decide the further course. Meanwhile, you will put start some management.
Yes, loading. Once we make the diagnosis of STEMI.
Before ECG, oxygenation or something.
If saturation is less than 90%, then we should provide oxygen support to the patient.
Okay, now we'll move to ECG. Okay. Yes. What will you see in the ECG?
ECG, first of all, the ST segment elevations. Irrespective to which wall is also involved, we should interpret the anatomical classification basically. So, and in ECG, suppose, first of all, in the ECG, we also should know which artery supplies which wall of the heart. So it will be easier for us to know which artery is basically occluded. So if, for example, if we see elevation, the 3 main 2 coronary arteries are supplying to the heart. That is right coronary and left coronary. The left coronary further divides into left circumflex and LAD. So which branch is supplying which wall respectively, we can classify the MI. So if there is elevation, ST elevations in V5 and V6, the LAD is supplying the lateral wall of the MI. So it will be a lateral wall MI and the occlusions will be in LAD. If, anterior wall.
Okay, for that, those who are listening, they should understand that we are doing ECG because still, till this date, reperfusion therapy is based on whether your ECG is telling you it's an ST segment elevation MI or non-ST segment elevation MI. This is very, very important, because in ST segment elevation MI, you will provide reperfusion therapy, while in STEMI, you need to provide reperfusion, but it can be, we can wait for that elective PCI. Also, before that, can you tell us about some unstable angina also, Radhika? What is unstable angina? I'll tell you, in which the patient has symptoms, but there is a cardiac markers are not elevated, means the myocardium is not damaged. So you made a diagnosis of ST segment elevation MI and STEMI.
Yes, sir.
I was asking, if you don't see ST elevation MI, what are the conditions where you can miss that it's a STEMI, though you see ST depressions in anterior leads or depression in all the leads?
If there is a depression in all the leads, but elevation in AVS, posterior MI, if there is an inferior MI changes in second, third, and AVF, we should also see posterior leads. We should also check the posterior leads.
Inferior posterior MI will have ST depressions in the anterior leads, because if it's a posterior MI, so if you put an ECG at the back of some patients, then it will show ST elevation. Now there is two more entities which is to be addressed. Sorry, this is for this. So if there are depressions in all the leads of ECG, but AVR is elevated, that means it's an left main is involved. One more is new onset LBBB. It also comes under the category of STEMI. So ST segment elevation MI, you know that, but don't miss inferior posterior or left main disease and your new onset LBBB. Okay, so you have an idea now. Avni has shared in the chat box image by which you can localize the different sorts of MI. Now, treatment part in STEMI, one MI which needs to be picked and differentiated from others, because the treatment changes in that is which MI needs to be seen and picked. It's a STEMI only, but the treatment part differs. Some treatment part differ in that. Reperfusion will give, but we need to give fluids in that particular MI.
Inferior volume.
Inferior wall MI. If it's a RV infarction, you need to fill the patient, not overload, but you need to fill the patient, so that the treatment part varies. So you just observe whether we are dealing with RV infarct or inferior wall MI. Not every inferior wall MI is an RV MI, but RV MI keep a possibility. So, okay, you have decided, you have seen that this is an STEMI. Now, how the algorithm proceeds from here? Management and reperfusion therapies proceed from there.
First of all, we should start with the loading dose, whether we are taking the patient for the thrombolysis or else PCI. The loading dose, we are loading the patient with dual antiplatelets, statins, and anticoagulants. The aspirin dose, the loading dose of aspirin should be from 165 to 325. And if we are loading
chewed. Chewed and swallowed. Then?
And if we are giving him a clopidogrel, so the dose should be 300 to 600. If we are loading him with the ticagrel, then the dose should be 180 stat.
Prasugrel?
If prasugrel, that we only should load at the time of PCI, that should be 60 mg stat.
So we had a YouTube short today on this. A little bit more about this. If you read the text, what is the line mentioned in the text is, look, it should be given, prasugrel should be given in which you are taking the patient for PCI and the coronary arteries anatomy is known. That means coronary anatomy means you are sure that we can put a PCI stent in one particular of the artery. We are not going for CBG because the bleeding risk is very high in such patients. So when your coronary anatomy is known and you are going for intervention, then only you should give prasugrel. It is not indicated for the medical management of acute coronary syndrome. Ticagrelor is more potent, but it's a reversible inhibitor of platelet. It should be used ideally in all patients, especially in high-risk patient, but bronchospasm is something which you need to understand. It's a short half-life, that's why it's given in the BD doses. And also regarding clopidogrel, you should always in long term remember that there is something called clopidogrel resistance. Some patients have clopidogrel resistance, so they may not develop the antiplatelet effect as required. So now you have loaded with antiplatelets, statins. How much statin you will give?
80 mg.
Okay, atorvastatin. And then anticoagulant, how much?
If we are using heparin, then the dose should be from 80 to 100 units, maximum of 4,000 to 5,000 units stat, followed by 12 units per kg. That is maximum up to 1,000 units followed dose.
This is unfractionated.
Yes, sir. If we are using an subparam, then the dose should be if patient's age is less than 75, then bolus dose should be given, that is of 30 mg stat, followed by 1 mg per kg BD.
This is for which age?
Less than 75.
More than 75?
Then we should avoid bolus dose and follow 0.75 mg per kg subcutaneously BD.
Very nice. So now you have given the antiplatelet, dual antiplatelets, you have provided anticoagulation and statins. Now you need to reperfuse the patient. So what is the strategy? What should be the preferred modality?
Always the preferred modality will always be PCI. But in some conditions, like if PCI is unavailable or there is a late in a transportation of patient to PCI center, or PCI is completely contraindicated, then we should consider thrombolysis. So fibrinolytics are the drug of choice for that.
Before coming to fibrinolytics, like this duration needs to be understood. So what is the, first of all, what is the window period until which you can thrombolize?
Less than 3 hours. Basically less than 120 minutes, we should thrombolize the patient, or if the contact to needle time should be less than 30 minutes.
No. I'm not asking this contact. I'm starting from symptom onset. What is the window period?
Within 3 hours.
If the patient comes, suppose he comes to your emergency and says that I have a chest pain for 6 hours duration.
No, the first no. Then he is out of window period.
Anyone here? Anyone here can answer in the chat box that what is the time period, window period up to which you can use reperfusion therapy or thrombolize the patient in emergency for STEMI? What is the window period? Anyone? From symptom onset. Anybody who are prompting can answer. Not an issue. Rahul, very nice. So somebody has iPhone 12. I don't know the name. What is the name of this iPhone 12? But Rahul has mentioned 12 hours. So it is correct, from symptom onset up to 12 hours, you can thrombolize. The earlier, the better. The maximum benefit is achieved in the early hours. That is a different story. But up to 12 hours, you can reperfuse. In what conditions you can extend the window period? Suppose the patient comes after 15 hours. So can you include in certain conditions? Anyone? Abhi, Benjamin? Okay. So if the patient still have ongoing chest pain, and you are and the second condition is if you are feeling that this patient is landing in hemodynamic instability, or the infarct size is going to be hugely involved, big area of the heart is involved, infarct is involved, so you can extend the window period up to 24 hours in case persisting chest pain is there, or you feel that a large area of myocardium is involved. In those cases, you can extend the window period. So window period is 12 hours from symptom onset. Now this is from symptom onset. Symptom starts at home or somebody working in your office or somewhere. Now we come to your door to needle or door to balloon time. So what are those when the patient makes a first emergency contact? Now we have two scenarios. At one place you will be having a PCI facility, and other places you will not be having a PCI facility. So how will you manage this?
If PCI
If-
is not available,
First we'll discuss if PCI is available.
if PCI are available, then patient the window period should be
No, window
less.
period. Window period we have discussed. Ki within 12 hours we can thrombolize or do a reperfusion therapy. But now if this person makes a contact in a PCI, means where PCI is available. So how much
less
time?
than 60 minutes.
Less than?
Within 60 minutes.
So door to balloon time is?
Less than 60 minutes.
Sure. Door to balloon time is 60 minutes.
Maximum time 60 minutes. Yes.
Pakka. And what is door to needle time?
Door to needle time, if at PCS should be less than 30 minutes.
Somebody has Abhi is unmuted. No, I'm asking door to needle time and door to balloon time. Door to balloon time means from the patient entry to the hospital, and you have taken the patient to cath lab, you put in stand and you have inflated the balloon. So the reperfusion is, so door to balloon time is 90 minutes, less than 90 minutes. Within 90 minutes, the balloon should be inflated, means the reperfusion should have started. And what is door to needle time means you have put a needle and you have started the thrombolysis. So how much this time should be?
Less than 30 minutes.
Less than 30 minutes. So this is, if a PCI is available, we'll do a PCI. Now suppose he lands on a center where PCI is not available, like in Devas or any nearby area where PCI is not available. So how will you decide what will you do?
Then we should go for thrombolysis till patient transfers to TCA center.
Now, suppose the distance of travel between that rural area and our center is 60 minutes.
60 minutes. Then we should send him after loading dose immediately to the PCA center as soon as within 30 minutes.
And suppose the PCI is available in Bhopal only. The travel time is 3 hours. Then what you will do?
We will thrombolize the patient at our center.
What is the criteria for it? What is the criteria?
If the travel time is more than 120 minutes, then we should thrombolize the patient.
If you cannot make the patient send to a center, which it will take more than 2 hours, you need to thrombolize the patient and then plan shifting. If you can send them within 2 hours, then you need to send them as early as possible. Understood this? Very, very clear. Anybody has doubt in this? Okay. Now, what is the once we'll discuss this thrombolytic agents and other all things. What is the role of troponin in such patients? Means for diagnosis of MI, is it necessary you should do a troponin if it is HC elevation MI?
No, it is not that significant, not that important.
So what is the importance of troponins in STEMI?
In STEMI, to see the ongoing infarction, if it is an increasing trend, so
and there is one more marker, CKMB. So why troponin is preferred? So firstly, in STEMI, what is the role?
Very, it is a rise in very initial hours and very specific to the myocyte infarctions. So we can post MI within 4 to 6 hours, it will rise. So that is more significant to make the diagnosis.
CPK, so you have made an MI on the basis of ECG, first of all. So troponin has got a prognostic value. It has not got a diagnostic value in this. Diagnostic value of troponin comes in STEMI, where you have some ECG changes and then you send a troponin level and you find that it is elevated. And it should be sent after 3 hours. You can send at the admission and then repeat after 3 hours if it's an ultra sensitive, otherwise after 6 hours. But in STEMI, it has got only prognostication significance, not for the diagnosis. Now, CKMB and troponin levels. CKMB rises acutely, but the problem is it falls also very fast. While troponin value can remain elevated up to 2 weeks. So that's why the chance of missing an MI is less with troponin. So this is the significance of troponin level. So we were there at thrombolizing this patient. Suppose this is a rural center and we need to thrombolize. Is there a condition where in our center where both PCI is available and thrombolysis is available, but we cannot thrombolize? We have to take this patient to PCI. We cannot give the option of thrombolysis to that patient. Are there any contraindication to thrombolysis?
Yes, there are many. Some are absolute and relatives also. The absolute contraindication includes any history of intracranial hemorrhages of the patient, any ischemic stroke within 3 months. If patient is a known intracranial malignant neoplasm or any active bleeding within 2 weeks, or patient is suspected of aortic dissection or any history of closed head or facial trauma within 3 months. These are the absolute contraindication. The relative contraindication would be if patient is having a severe hypertension that is more than 190 by 110 of blood pressures. If had CPR more than 10 minutes, any ischemic stroke more than 3 months, if already on any anticoagulants and his INR raised up to 2, or if patient is pregnant or had any recent surgery or any trauma within 3 weeks.
You said that patient's blood pressure, how much should be the patient blood pressure? Relative
More
contraindication.
than 190 by 110.
And this should be with medication, without medication?
With medications.
With medication. If the BP is still on this with medications, you need to. If the patient is in cardiogenic shock, then
a patient should be taken immediately for the PCI,
PCI.
and inotropes should be started.
So no thrombolysis. We will not thrombolize this patient. Suppose this patient has been thrombolized with STK streptokinase 2 years back. Then
we cannot again thrombolize till 5 years with the STK. So also patient should take for the PCI.
Why we cannot thrombolize this patient with STK streptokinase now?
Because it makes antibodies already.
So anaphylactic reaction and efficacy both will be compromised. Okay. So now the choice of agents. You have non-specific one is streptokinase and other ones is specific, fibrin specific, tenecteplase, alteplase and reteplase. So which is preferred and why?
In usual practice, we prefer reteplase because of its easy dose calculation and less complications. So we can easily.
What are the less complications? What less complications?
Less complications. Bleeding.
If you go by studies, still tenecteplase is preferred over any reteplase or alteplase. Ease of administration, you don't need to give bolus doses, and also the bleeding risk is less with tenecteplase. So you can read, there are 2-3 studies which has compared this tenecteplase with reteplase. And reteplase, you need to give 2 bolus doses at specific intervals. Now, very, very important thing you need to understand. STK streptokinase is all the effect. It's an anticoagulant effect, antiplatelet effect, antifibrinolytic effect. And this is a non-specific fibrinolysis. The chances of bleeding are there because it will dissolve the fibrin wherever there is in the body. While this fibrin specific agents will always fibrinolysis will be done where there is a clot. And once the fibrin has been lysed, there will be again a rough area which will again act as a source for clot formation. So antiplatelets and anticoagulants are mandatory for this fibrin specific agents. They needs to be given. Otherwise, you will fibrinolysis will be happen, and again the thrombus chances will form. So in clinical practice, though it is not documented, streptokinase with streptokinase, you don't see rethrombosis very fast, but in fibrin specific, if you don't give your anticoagulants, then the chances of again clot formation becomes high if you don't give antithrombin agents, means your normal anticoagulants. So these are the agents which you give. Then now, if there is no contraindication, we should go for PCI. Percutaneous coronary intervention. So we have discussed on the basis of ECG how we can diagnose which sort of MI, anterior MI, anterolateral MI, inferior posterior MI, or your right bowel infarction. You can go on anywhere, the ECG table is there. Now, once you have, what are the mechanical complications which can happen in an MI?
Complications.
Mechanical complication which can happen in MI.
I think free wall rupture.
You can come in front and say.
Free wall rupture है, aneurysm है.
LV wall aneurysm.
LV wall aneurysm and
mitral regurgitation.
MR.
Capillary rupture. Septal defect can also occur. VSD. So it is very, very important to all the residents who are listening this session. Whenever a patient of MI comes and he is in cardiogenic shock, or even if it is not in the cardiac, always put in a stetho on the chest of the patient. If you see a murmur or a pansystolic murmur or a diastolic murmur, this is an indication that this patient is in has developed some mechanical complication which will require further intervention to support, or patient may be required to go for surgery. Now, suppose the patient has any one of them, so that will be a surgical complication, surgical things. Now, if the patient is cardiogenic shock, so other than your vasopressors or anatropes, which vasopressor anotrope you will use?
ADR.
Adrenaline. It's adrenaline and plus minus dobutamine. These are the recommended ones. But if the BP is not coming, anything which you can use in cardiogenic shock, any other modality? IABP. You can use intra-aortic balloon pump. You can use to support the heart. Studies have shown that IABP alone will not going to help, but it will help to in handling this cardiogenic shock, which can be of benefit to the patient. So then, depending upon the condition, you need to manage shock and all other things, whatever recommended. Now, there is one CLIP classification of cardiogenic of MI. You know. Patient with no cardiogenic shock and with cardiogenic shock, like that. You will again go and read. So now, once we were still some points remembered to be remembered in thrombolysis. Suppose we have started the thrombolysis by streptokinase or any other fibrin specific. So when you will record the ECG and when you will say that this is a successful thrombolysis?
After 90 minutes, we should repeat an ECG. If once the symptoms, the chest pain is subsided completely and the ST elevations are reduced to more than 50%, then we consider it is at a successful thrombolysis.
So if suppose the ECG is not showing 50% downward trend of the ST segment elevation, what you will do?
Then
Or
we
the
should go
chest
to
pain. So after thrombolysis, if we are going for
rescue PCI.
PCI for reperfusion, it is called rescue PCI. Suppose you have thrombolized a patient at 1 p.m. So and how much time you can take for rescue PCI?
1 a.m. Then we have to wait after 90 minutes. Within 120 minutes again.
Anyone?
I have lysed at 1.
You have lysed at 1 p.m. Thrombolysis you lysed at 1 p.m. and now you want to this, and after 90 minutes, already 90 minutes has passed.
Yes.
So you took after 90 minutes, you took an ECG and it showed failed thrombolysis. So you plan for rescue PCI. So when will you take? When can the patient be taken?
Within 60 minutes.
Within 2 hours.
Within
90 minutes to 2 hours. The time frame is within 90 minutes to 2 hours. That time frame patient should undergo the rescue PCI.
What I read is 3 hours from the start of thrombolysis. If within 3 hours, after 3 hours, you can successfully take the patient for. So why we need to wait? Because chances of bleeding are less, because there will be a puncture, a femoral puncture or radial puncture. Radial technique is preferred. Radial technique is preferred. Now, one more thing. Suppose a patient comes and this patient has an MI yesterday and now 24 hours has passed. So what are the benefit of doing PCI in these patients? Means there was a complete blockage of the vessel. Patient is hemodynamically stable. And now you do an angio, you found 99% blockage in that vessel. Suppose it was an interval MI, 24 hours have been passed. And now patient is hemodynamically stable, there are AC changes, and you do an angio and you find 99% of 100% blockage. What is the literature shows to do angioplasty or not?
Angioplasty should be done.
Anyone else? There is a recommendation. There is no recommendation, or you can see that there is a very low grade recommendation for a occluded vessel post after 24 hours for PCI, because they say that the myocardium has already been damaged. But even after 24 hours, if you see a patient is having some chest pain, that means there is some part of the heart which is viable, which is sending the pain signals. So then PCI is means angioplasty is indicated. But post 24 hours, I'm not having that slide, otherwise I have shown you that post 24 hours of an occluded vessel, completely occluded vessel, PCI is not recommended, because the myocardium is already damaged. And I want everyone who is listening should go and see this. It is mentioned in each and every book, whether it's a Washington, O's, Harrison, textbook of critical care. Every day there will be a table, there will be 3 recommendations. 1, within 12 hours. 2nd, from 12 hours to 24 hours, you can extend if there is ongoing chest pain or something like that. And then 3rd, post 24 hours, there is no recommendation. So this is something everybody should. Right. Okay. So this we have discussed. For end STEMI, obviously, if there is elevated troponin, you as soon as possible you do a reperfusion therapy with PCI. That is something you should know. Anything which I am missing in this? Most of the things we have covered. Anyone has doubt, you can unmute and ask. So we have covered what is acute coronary syndrome, what are the symptoms, how on this basis of ECG you need to define STEMI versus end STEMI. Then what are the mimics you should see for STEMI. Then you should not miss inferior posterior MI, AVR elevation, new onset LBBB. Then what are the loading dose you will given, which dual antiplatelet you can use when. Then when you will do thrombolize, when you will do PCI, if your PCI is available, not available, when you will transfer, not transfer, where thrombolysis is contraindicated, where PCI should be done, and what are the mechanical complications of MI, doses of various drugs you can go read. Post 24 hours in occluded vessel is not recommended. Any role of beta blocker in STEMI or NSTEMI?
In STEMI, it plays important role. We should give 5 mg repeated 3 doses of beta blocker at the diagnosis of STEMI because it prevents the ventricular arrhythmias.
So the IV dose is recommended or oral is recommended?
IV.
What is written? You tell me, not what you're seeing.
No, in Washington, I read that IV doses of 5 mg, 3
Okay.
doses
Okay.
should be given.
In NSTEMI also?
In STEMI. Yes, in STEMI also.
Just
But-
have a look whether oral or IV recommended. You can read that. Also, if the patient is having cardiogenic shock, don't give it. There is no role on it. Anything else? Anyone from the forum? If we are missing something? I'll tell you that TIMI classification also. Sorry, I told you, this. Just a second. Hold on. Phillips. Sorry. Phillips classification. So it is graded in 1, 2, 3, 4. Means it is for STEMI complication and mortality. So if it's a patient STEMI present with no heart failure, it is Phillips classification 1 and it has got 6% mortality. While if we go to 4th one, if the patient is in cardiogenic shock in a STEMI patient, then it is Phillips classification 4 and the mortality is 81%. Now we have 2 and 3. So in 2, there is a mild congestive heart failure. There is a mild congestion on the chest X-ray, but the patient is not that much symptomatic. But you feel on X-ray that this is something is mild, very mild. Then it is at 17% mortality. But if the patient is in frank pulmonary edema, but no cardiogenic shock. If the patient is having frank pulmonary edema, then the mortality is 38%. So if the patient is not having cardiogenic shock in STEMI, 6% mortality. With cardiogenic shock, 81% mortality. If the patient is in frank pulmonary edema, then you have 38% mortality. And the patient, if is not frank pulmonary edema, there is a mild chest congestion, then 17%. So Phillips classification 1, 2, 3, 4. So this helps to you to get alert while seeing such patients. Dobutamine and adrenaline are the preferred ones. If the BP is maintaining, you can also take a use of nitroglycerin. One very, very important thing that sometimes patient come and they have a chest pain of myocardial infarction and they take sorbitrate and the patient gets settled and we make a diagnosis of MI or unstable angina sort of. What is the most common differential of this thing which gets relieved by sorbitrate? Same pain, same nature of pain, and it gets relieved by sorbitrate also, but it is not related to heart. And it is a mimic of unstable angina or MI. Anyone?
Not related to heart.
It is not a cardiac condition, but it behaves in the same manner. The patient will present with typical chest pain. The patient will the pain will
Prince metal angina?
No. What is Prince metal angina? In this, the vessels are normal. This is because of spasm of the vessel, but it's still again of the heart.
Okay.
Anyone? It will get relieved by sorbitrate. Anybody has listened the term nutcracker esophagus? Benjamin will Google it very fast. Or Avni also is very smart. He can nutcracker esophagus, a mimic of MI. You can you can Google and let me know. You got it? Hmm?
Yes, sir. Yes, sir.
You got that?
Yes, sir. Swallowing contractions are too powerful.
Huh.
It is relieved by nitrates and calcium channel blockers.
So it is one of the differentials for unstable angina. Okay. Now, one more thing. Now, timing of this is one table, very important table. Timing of urgent coronary artery bypass in patient with STEMI in relation to the use of antiplatelet. Suppose this patient is having Radhika, you can unmute. So, suppose this is a patient of MI, and because of any complication, you find that this patient needs to be taken for CABG. So, which antiplatelets needs to be stopped when? So, when you will stop aspirin? Urgent CABG, I'm asking. Will you stop aspirin?
If patient is already on antiplatelets or
We have a STEMI patient, and now we want to take to urgent CABG.
if we are suspecting a CABG patient, we should not load the patient.
No. Ye concept, where from this concept, from where this concept came?
Read it.
This is a patient of acute MI who presented with STEMI. You loaded the patient. You will not wait. At the admission, you don't know whether this patient will turn out to be a triple vessel or left main stem, anything like that. You will give dual antiplatelet. That's for sure. So I'm asking, this is a good table. So which antiplatelet needs to be stopped, whether needs to be stopped firstly, and whether needs to be stopped, and then the duration. So the drug aspirin should not be withheld before urgent CABG. Urgent CABG, I'm asking. So for urgent CABG, aspirin should not be stopped. This is a class 1 recommendation. All which I'm telling you is our class 1 recommendation, and its level of evidence is C. Clopidogrel and ticagrelor. Discontinue at least 12 hours before urgent on-pump CABG. They should be stopped. Now, if you have, we forget to discuss one agent is glycoprotein 2B3A receptors. These are the tirofiban which you use. These are used when you find that the thrombus load in the vessels is very high. So you give tirofiban. So tirofiban should be discontinued at least 2 to 4 hours before urgent CABG. Then you have apeximab. Discontinue at least 12 hours before urgent CABG. So these anticoagulants and antiplatelets means these all tirofiban, clopidogrel, you need to know when these drugs needs to be stopped before an urgent CABG. Just I'm checking one few minutes so that I can check and see if we are not missing something. ACE inhibitor should also be used in such patient to prevent remodeling.
Yes.
So okay.
So
So this was in, I will say, bird eye view or a short discussion about acute coronary syndrome. This session, all these sessions are meant to sensitize you regarding the topic so that you need to know what are the practical aspects which we need to be taken care of, and while reading we need to stress on such key points. I think Ankit is also here somewhere. Okay. So Ankit will take the next session. So I hope everybody will find it useful. Even if they don't find useful, at least they will get sensitized regarding these sessions. Go and read now acute coronary syndrome within 48 hours for sure. Go and read from O's Manual of Critical Care, Intensive Care, or from Washington Manual, or whichever book you have. Once you read it after this discussion, at least 60-70 of the things will remain in your mind for a longer period of time, and then discuss with your friends. So Abhi and any Benjamin, anyone, Prerna is also here. Anybody wants to say? Ayushi, nice to see you even after resignation. Thank you. So anybody wants to say anything, add on anything, or we can stop the session? And we will upload it on the specific members group channel, group link, so that you all people can listen to it later on also. Okay, so we can end. Thank you, Radhika. Good
Thank
work
you so
done.
much.
But before ending this, what will be the topic of next Thursday session?
Noting this section.
Hmm?
Arrhythmias.
Arrhythmias or aortic dissection anyone.
Arrhythmias. ठीक है. Okay, we can take arrhythmias next time. So it will cover all the arrhythmias. Okay.
Yes, sir.
So thank you. Ankit will take. Good luck to Ankit. Chalo. See you next time. Thank you.
Thank you, sir.
Good night. Good night.
Thank you.